Hello, imagine this. You're in the PACU and your patient's blood pressure is escalating fast. You're now facing a hypertensive crisis where every second counts. Your choice of agent is critical. In moments like these, hydralazine is a tool many of us consider. In this Dr. Mech Anesthesiology series explainer, we're going to do a clinical deep dive on this potent, fast-acting vasodilator. All right, before we get started, our standard disclaimer. This content is for educational purposes only. It is not intended as medical advice, so please consult with a qualified healthcare professional for any medical concerns.
Just so you know, all the information we'll be covering today is taken from established, peer-reviewed clinical sources.
Here's how we're going to break it down. First, we'll frame the hypertensive emergency. Then we'll get into hydralazine's mechanism of action. After that, we'll cover dosing, then the really critical contraindications and side effects, and finally, we'll wrap up with monitoring and key considerations. So, let's start by framing the clinical challenge itself. The scenario is one we've all faced: acute, severe hypertension in the perioperative setting. The immediate question is, what are you reaching for? What are your go-to considerations for rapid, effective control? And this is where hydralazine often enters the conversation. It's a first-line agent not just for general hypertensive emergencies, but it has a very specific and important role in acute onset hypertension in pregnancy and postpartum. You'll also see it used for tough-to-treat essential hypertension and in some heart failure protocols along with nitrates.
Okay, Section 2. Let's get into the pharmacology and understand exactly how this therapeutic tool works.
So, what is hydralazine at its core? It's a direct-acting peripheral arteriolar vasodilator. Its main job is to cause a significant drop in peripheral vascular resistance. It directly targets and reduces the afterload. Now, the cellular mechanism, while not 100% confirmed, is theorized to work in a few key steps. It's thought to inhibit IP3, which then stops calcium from being released from the sarcoplasmic reticulum in smooth muscle cells. The end result? Myosin phosphorylation is inhibited, which prevents the arterial smooth muscle from contracting, and you get vasodilation. But here's the crucial consequence of that rapid vasodilation. The sudden drop in blood pressure kicks off a powerful compensatory sympathetic response mediated by our baroreceptors. This triggers a release of epinephrine and norepinephrine, which, as you know, leads to a significant jump in heart rate and cardiac output. We call this reflex tachycardia, and it's a huge part of the hydralazine story. Moving on to Section 3, let's talk about the practical side, how we actually use it in an emergency situation. This pharmacokinetic table really tells the story of why the IV route is essential for emergencies. Just look at the onset time for IV, 5 to 20 minutes. Compare that to 45 minutes for an oral dose. Its peak effect hits within 15 to 30 minutes, giving you that rapid response you need in a crisis. For a hypertensive emergency, the standard intravenous dose is 10 milligrams, given as a slow IV infusion. Your maximum initial dose shouldn't go over 20 milligrams. And, depending on the clinical picture, this dose can be repeated every 4 to 6 hours. We've now arrived at what is arguably the most critical section for patient safety: the contraindications and adverse effects. There are several absolute contraindications, situations where you should not use hydralazine. These include patients with known coronary artery disease, anyone with a suspected or confirmed aortic dissection, and those with systemic lupus erythematosus. Using it in these patients can be incredibly dangerous. You are watching the Dr. Mech Explainer series. Let's break down the why behind these contraindications. In a patient with coronary artery disease, that reflex tachycardia we talked about dramatically increases myocardial oxygen demand. This can easily tip them into angina, ischemia, or even a full-blown infarction. And an aortic dissection, that sudden drop in afterload might sound good, but it actually increases the shear stress on the aortic wall, which can make the dissection worse. Now, another critical concept to understand is the slow acetylator phenotype. This is a genetic trait. People with this phenotype have an enzyme that metabolizes drugs like hydrazine more slowly. This means they end up with higher levels of the drug in their system, which puts them at a much higher risk for toxicity. And you might be surprised at just how common this is. We're talking about 50 to 65% of white and black populations being slow acetylators. This is the direct link to why there's such an elevated risk of developing drug-induced lupus erythematosus, or DILE, especially with long-term therapy.
Okay, let's bring it home with our final section, monitoring and key considerations for best practice.
When you give this drug, vigilant monitoring is non-negotiable. That means frequent checks of blood pressure and heart rate, especially after you inject, because the maximal effect can happen anywhere between 10 and 80 minutes later. If a patient is on prolonged therapy, getting a baseline CBC and an ANA titer is essential, and you'll want to repeat those labs periodically to watch for any issues. So, what are the crucial takeaways? First, hydralazine is a potent, fast agent for true hypertensive emergencies. Second, you must always anticipate and be ready to manage reflex tachycardia, often by co-administering a beta blocker. Third, remember those absolute contraindications: CAD and aortic dissection. Fourth, always keep the risk of DIL in mind, especially for slow acetylators on chronic therapy. You are watching the Dr. Mech Explainer series. If you're finding this content valuable for your clinical practice, please take a moment to subscribe to our channel and press the bell icon so you're notified about our latest explainers. And we'll leave you with a question to reflect on. Given its potent but sometimes unpredictable response and its long duration of action, where does hydralazine fit in your personal algorithm for managing acute hypertension, especially when you compare it to newer, more easily titratable agents?